Hi, good morning, everybody, and thank you for coming to breakfast at today. So today we have two sessions. I would be the first moderator for this session. So let me start by introducing our speaker. Our speaker is Dr. Rumana Akhter Saifi. Dr. Rumana is a senior lecturer at the Department of Social and Preventive Medicine, Faculty of Medicine, UC Malaya. She joined us in 2024, and she holds a PhD in demography from Mahidol University, Thailand, and an MPH from University of Auckland, along with degrees in economics. Since joining Rumana has become a member of the Center of Population Research. Her research focuses on public health with strong emphasis on HIV prevention and related areas. She is a PI in research projects including those related to HIV care, transgender women, and Malaysian implementation science training program in HIV. Her research is supported by international funding. Dr. Rumana actively participates in the academic community as a course coordinator and committee member. So without wasting any time, I would like to share the topic that Dr. Rumana is going to share with us today is from wire to wireless. Preparation to take. Telemedicine behind the prison wall. Dr. Rumana, you may start whenever you're ready.
Thank you very much, Prof. Victor, for the nice introduction. Can you all see my screen?
Yes, we can see your screen. Can you please continue?
Okay. Thank you very much. Let me so the title of my presentation is From Wire to Wireless, Preparation to Take Telemedicine Behind the Prison Walls. So as the title goes, from wire to wireless, you must be wondering that why I am using this particular title. Actually, it's a metaphoric phrase, and it's widely used when we talk about telemedicine, telehealth. Yeah, so in simple words, it means a digital platform, and also it means remote healthcare services. I'll be talking about two models here: telemedicine in community setting and telemedicine in prison setting. So I'll start my presentation by giving a description about digital health. What do we really mean by digital health? So digital health means remote health, actually, and where we use technology in order to provide healthcare services. And it also includes training services for the healthcare service providers. And the benefits of digital health, of course, it expands the reach. It reduces barriers. When we talk about barriers, cost is a huge issue. It can cut cost, travel time, stigma is there for marginalized population. It can always use accessibility, and it can always improve the service delivery, continuity, and trust. Most importantly, it can empower the workforce. And when we talk about expanding the reach of healthcare services, it has a huge implication on equity as well. Now, there are certain components of digital health, actually. We can think of digital health like an umbrella, a huge umbrella under which e-health, m-health, telehealth, telemedicine, everything can fit in. Although in today's presentation, I won't talk about m-health, I'll concentrate on telehealth and telemedicine. All of these components are associated with technology, which is the name of the game in today's world. Now, when we talk about telehealth, it's like a broader application of technologies, and it also incorporates education. Okay, when we talk about telemedicine, it only concentrates on healthcare service delivery. Okay, the training component is not there when we talk about telemedicine. So let's try to define telehealth first. Telehealth is the delivery of healthcare, health education, and health information services via remote technology. So if we try to compare between telehealth and telemedicine, telehealth refers to more wider range of digital healthcare services as well as activities. We cannot use both of these terms interchangeably. And when we talk about tele-education, tele-consultation, these all fall under telehealth. Now, in today's world, we are talking a lot about telemedicine. We are talking about technology, use of technology in healthcare services. But if we look at the history, in fact, use of technology is not a new concept for the healthcare professionals. In 1960s, NASA scientists first used technology in order to monitor the health of the astronauts. And then if you even go back farther, when ECG was first discovered, that was also a huge innovation in terms of technology. So the concept of using technology in healthcare was always there. The concept of remote provision of healthcare was always there, but it gained popularity in recent days. Now, if we look at the potential for telehealth, WHO has identified a few very important components where telehealth has huge potential. First of all, telehealth can address workforce and resource shortages, which is always a huge issue across a resource abundant and resource scarce country. And of course, the traditional barriers to healthcare services, which is travel time, cost, physical hardship, stigma, it can be minimized when we embed technology and provide healthcare through remote system. As per WHO estimate, WHO projects a shortfall of 10 million health workers by 2030. And this projection is mostly for low and lower middle income country. However, as I have just mentioned, countries at all levels of socio-economic development face or will be facing shortage of workforce, especially in healthcare in coming years, according to the WHO projection. And in order to fill this gap, telemedicine can be an answer. Now, telemedicine can be like from provider to client or client to provider interaction, and it can also be interaction between provider to provider in order to provide better healthcare services. And I'm sure most of you know about Project Echo, which is like a teletraining platform, and it is provider to provider interaction. Now, if we look at, thank you so much, and I apologize. Yeah, I'll move on very fast now. Now, if we look at Malaysian guideline, the future projection has mentioned very clearly that decentralization will be the name of the game, and integration of community partners with the public sector will be a potential component for future healthcare services. So now I'm going to discuss very briefly about two tele medicine model that we have tried to test both in community setting as well as beyond community setting. And when I say beyond community setting, I mean close setting, which is prison, yeah, behind the prison wall. Okay. So what we did, we tried to explore telemedicine in order to improve healthcare engagement among individuals who are transitioning from prison to the community. Okay. So when I say who are transitioning from prison to the community, I mean the post-release prisoners. Yeah. And we tried to incorporate a human-centered design approach. When I say human-centered design approach, I mean we tried to engage the community, the end users of the intervention from the very, very beginning. So this particular study investigated the acceptability and feasibility of telemedicine among people who are using drugs. Okay. So these were the participants, the post-release prisoners, and at the same time, they were using substances. In order to make the things accessible to the research participant, we brought a layer between patient and doctor in order to establish the telemedicine model. And this layer was the NGO, the community-based organization. So they were the mediating factors between the patient and the doctor. So this is how the entire, when we developed the telemedicine model, it looked like this, okay? So the community-based partners, they assisted the clients to make an appointment with a healthcare professional. By that, I mean a physician, okay? And the patient had to present himself on that scheduled day, not to the facility, but to the NGO. And this is to decrease the internalized stigma among the research participants. Please note that we are talking about post-release prisoners who are drug users at the same time. So we used the appropriate devices in the NGO setting and then connected the patient with the doctor. Okay, I have a small video to show all of you, but due to time constraints and technical glitches, I won't be able to show the video, but let me just explain very quickly. So we created a demo video, and this demo video actually explained the entire telemedicine model. And we took opinions from 30 clients, 10 NGO workers, and 10 doctors about the model that we created in order to take telemedicine model to the post-release prisoners. Few of the results from the qualitative finding I'm just sharing with you. I wish I had more time. So one of the research participants, he mentioned that actually the location was quite far. I mean, the doctor's clinic, and obviously the issues of stigma was there. Okay. So when we brought in the community organizations, the grassroots organizations, as a mediator in between the two parties, it helped to overcome the barriers for the client. Okay. And these are the other two quotes. I once stopped ART medication for 6 months because at that time I didn't have any transportation. Remember, we are talking about post release prisoners, and many of them are homeless as well as jobless because they're trying to reintegrate themselves into the society again. So, lessons learned from this model. Telemedicine coordination actually can be time consuming. You know, like the layer between a patient and the doctor and the in between mediator, which is the NGO. This coordination can take some time, and it requires training as well, because remember, we are using the lay healthcare providers in order to provide like the basic healthcare needs to the patient. And of course, the question of wireless connection is there. For that, we need to provide backup services. And privacy is a key because there are huge ethical dilemma in order to run this model successfully. But of course, there are ways to overcome it. And then we conducted a survey also in order to understand whether the participants are interested to obtain telemedicine services. And we got very positive responses, and the sample size was 369. Now, I'll be talking a bit about telemedicine beyond community, behind the prison walls. And the reason I wanted to bring in prison because they are a neglected population. However, as per UN standards, prisoners' health should be considered as public health. And as per Mandela's rule, established in 2015, prisoners' health cannot be ignored, and prisoners should get equal treatment as the general public for health, even if it's behind the bars. So we try to try to identify the barriers and facilitators of telemedicine model in the largest prison in Malaysia, which is Kajang. So there are certain reasons that we chose Kajang prison. First of all, the prison is running over its capacity at this moment. And if you look at the ratio between healthcare providers and the prisoners, like we just have around 4 healthcare providers for 6,000 prisoners in Kajang. And prisons, as always, are hotspots for TB, HIV, and HCV. And you all know that these are all intersecting factors. So we tried to assess the feasibility of a telemedicine pilot at Kajang prison. So this is how the prison environment looks like. You can see like a sort of, we conducted NGT and also individual interviews, and the results were positive. I mean, we received positive feedback. Let's go to the last slide. Now, the key facilitators are like all is not looking bad. We received like very positive feedback. And for the barriers, they have mentioned about task shifting. They have asked for and stakeholders. With that, I'll end my presentation,
Yes.
Prof.
All right.
Victor.
Sorry about that. Sorry about the time taken.
I'm so sorry
I have time for one question. Anyone have any question to ask? Is there
I'm
any
happy
question?
if you want to contact me.
No, there's no question.
via email.
I think we just leave it here. And thank you very much, Rumana, for presenting. We have no time to continue because we have a second presenter, which is to continue after this. And we would, if you have any question, you all can just contact Rumana. Rumana is in our department of social practice medicine, and she'll be able to provide you with further feedback on that. Thank you very much. Thank you, Romana. Now I'll hand it on to Prof. Mary.